My name is Sölve Elmståhl, professor in geriatric medicine at Lund University, and I will share this session. And we will have the same as the first session with the two speakers and discussants, and then a general discussion before lunch. Well, integrated care, what is that? It is, of course, a way to put organizations together to improve outcome of healthcare, and especially to tackle questions regarding inequalities in outcome and access and experience of care. And often different key elements have been identified related to integrated care, like empowerment and education of patients, the inclusion of multidisciplinary teams, care coordination, of course, and as we heard in the first session, individualized care plans. And I think some of these elements will be discussed during this session and how we can use it and develop care. And first to introduce us is Helena Wittfeldt, head of R&D at Norrtälje Municipality. She will speak about 1000, integrated health and social care in Norrtälje. So please, welcome, Helena.
Thank you for the invitation to come and speak about Vårdbolaget 1000 and our ways to integrate health and social care in Norrtälje. As mentioned, I'm head of R&D, but also innovation and education, and keeping that holistic view helps us move further in health and social care. My presentation will be a bit about 1000 as a concept, for those who haven't heard about that and how we operate, but also about the challenges that we're facing and living in right here and now, and also about the different solutions and the ways that we work and improve our work methods. To start off about 1000, from crisis comes new ideas and innovative ideas. And in 2004, the Norrtälje Hospital was supposed to be shut down due to financial problems. But there was a small riot about this, and some brave politicians said, let's try something new. Let's put together an organization where we have both the municipality and care and social care together with healthcare from the region. And we started off in 2006 and continued as a project for 10 years, one of the longest projects we've ever had. But it was a way of understanding and learning as we were going, and we still do that. So we are a unique cooperation between Stockholm region and Norrtälje municipality. The different parts of 1000 you can see here on the list. So I don't talk about patients only. I talk about customers. We have them too. We have users. We have families, elderly. So if you hear me say one of these, I mean everybody. So here are the different organizations that we have, and we are situated at about 70 locations in Norrtälje municipality. This is a broad, wide array of different parts of the organization, and it's very important for us to collaborate and coordinate our efforts. Otherwise, we wouldn't do as good as we do, but we can still improve. I want to share our management model that we work with, and this is where everything stems from. And if we begin from the bottom, we have our core values: participation, safety, and respect. Everything stems from that. And then if you move up, you see one of the fundamental models for doing improvements. It's a constant way of always improving, and that can lead to improvement projects, but it can also lead to research and innovation. We focus very much on the needs. We need to work based on needs. And frankly, we don't have the time, energy, money, resources at all not to do so. So stemming from the needs is very important for us in order to develop our works. Health and social care, wherever you are, means two things, both where you are situated geographically. We are a vast municipality, and I will show you a picture of that soon. So it matters if you have 2 hours of traveling time to your nearest primary healthcare center, for example. But it also refers to where you are in life. You just had a kid, perhaps. You are divorced. Maybe you're 86 and moving into a retirement home. We have innovation as a very small part here, and when I talk to colleagues, I say that it covers everything, because it's a part of our DNA and how we work, constantly trying to improve the ways of working. And in the top, we have the core fundamentals that means that we cannot do this ourselves. We cannot do it by ourselves, and it shouldn't be on a single person or some spirit to do the whole work itself. We need partnership, and partnership was as a concept for us when we started working with this even more carefully, and we dived into the research about person-centered care, family-centered care, patient-centered care, and we said, we need something else. We have so many different stakeholders that we need to include in this. So we talked about partnership. And later on, partnership seemed to be actually a very good definition of what we're doing, because we cannot do this by ourselves. We cannot do it only together with patients. We have to do it together with our colleagues as well, and we need to figure out the needs of colleagues also. And referring to the implementation discussion, just briefly, I really concur with we need to make sure we understand the needs in order to have implementation, and then also sustainability. Employeeship and leadership are very important, of course, living in an area where resources are scarce. We need to think about that very often and every day. Moving on to the background. If we look at Norrtälje municipality, it constitutes 1/3 of the land area of Stockholm region. So it's quite big. As I mentioned, 70 different locations we are situated and delivering care and social care at. We have the archipelago, very beautiful. Might not be as beautiful as Scotland, but still we have a lot of islands, and we have a lot of distances, and we have geographical proximity, but also areas that are very sparsely populated, which is also quite different from the rest of Stockholm region. We have more elderly people living in Norrtälje municipality than the rest of the Stockholm region, as you can see here by the figures. So when talking about the future and more elderly, we are already there, and we have been there for quite some time. We don't have so many inhabitants in Norrtälje municipality, 65,000 right now, and it's projected that in 2040 about 83,000. But we have the summer effects. This is a real summer municipality with the archipelago and lots of summer houses. So in that time, that starts actually quite near in the future now, moving to Valborg and spring and summer. So we see a rise in inhabitants already now. But during the summer months, we see a double and a triple amount of inhabitants, which of course puts some stresses on our healthcare system and social care systems. If we look deeper into the population prognosis, we see that we increasing slowly but steadily. Those that we have most increase of is 76-year-old people moving to us. And that is due to many retirement, going to their summer house and living there permanently. We don't have as much 26 years old, as you can see here. We have the smallest increase there. And that's also connected to when you are younger, you move away from Norrtälje to study elsewhere and then perhaps coming back. Besides these demographical and geographical challenges, we also have a high unemployment rate. We have a low education rate. And besides that, we have a high incidence of diabetes, lung and breast cancer, and physical and mental health is quite poor. So we have a lot of challenges, and moving from those challenges, we need to think about our ways of working. How do we integrate? How do we move away from need, idea, to something that's implemented and sustained? I will talk a bit about the guiding principles of how we do this work. It's not just random. We would like to do even more, and the feeling after the first session here is I would like to invite everybody to just sit around the table and discuss ways of moving forward. But I will also share some of the examples of projects that we are running right now. So some of the guiding principles that we have for integrated health and social care, you can start basically anywhere. Integration and collaboration is a fresh product. You cannot do it just during some time and then rest on that, because new challenges arises all the time that we need to figure out. It can be legal, financial, or agreement. So we need to think about these all the time. And it's just like milk. If we don't treat it the right way or use it, it will be sour, and then you have to restart. The needs-based innovation is very important for us to gather the needs of the population, but also our colleagues. It's very important. As I mentioned, we don't have the resources not to base our development research on anything else. Partnership is very core and essential, and we have different educational programs, and we do this on everyday basis in 1000. We are not allowed to start any project, whether it's innovation, development, or research, if we haven't had partnership or investigated the needs. And that's because we see that it's very important, and otherwise it will come too late and make things take much more longer time. I will now share some of the examples that we have in 1000 that we are working on currently, and I will dive into depth in some of them, but not all of them. I'm sorry for the abbreviations in Swedish here, but I will give you the presentation of what it is. SAMS is one of our mobile teams. During the pandemic, we needed these, but actually they were started in January 2020, and little did we know about the process to come. But they are actually a very saving way of distributing health and care to our elderly. We have about 34 patients admitted to the mobile team right now, so they're acting like a virtual care department, so to say. They visit inhabitants in Norrtälje, usually over 85, with more than one chronic care condition, in their homes. And as you can see on the picture here, our Dr. Gabriel is visiting one of the elderly at home to see how we can help him. He has a COPD and needs care on everyday basis, but he is enough well to stay at home, because if he would be admitted to the hospital, we know what risks comes with that. So this is a new way of working, and Gabriel says that it's a tremendous way to work together with the patient in their home. Suddenly you have a sense and a feeling of everything. And since Gabriel is working at the hospital together with the nurse, Åsa, who follows him, and also assistant nurse, the patients are familiar to them in the mobile team. So we are developing the mobile team right now, because we see in the research we're doing about this, when comparing it to other efforts, that it's financially positive to do this, but also the health economics is being investigated. And the patients enjoy this way so much we can see right now, but we need to dive in further to understand the full picture. We have something else called Fokushuset, and this is for all ages actually, but we see that we have a lot of mental illnesses in the elderly population also. Here we don't focus so much on the diagnosis. We step away from that and we focus on what's your problem in your everyday life. It might be social interactions, sleeping, physical activity, and then Fokushuset puts together focus groups around this area of problem and help patients to move further. Just recently in January, we started up a group for families to patients who have an addiction problem. Very important to support families, otherwise we will have even more patients in the end. We have a very fun project about cell phones at our elderly homes and retirement homes. We conducted a randomized study on this, where one elderly home acted as a control group, and 2 other homes were given an iPhone, just like this. It's not a big deal. I guess all of you have one, at least one, maybe one for private and one for work. So this was actually not a very high innovation level, but stemming from the work process that are in these homes is that you have 1, maybe 2 computers that you sit by and do all the administrative work, and you do all the documentation. That can be a bottleneck. and the computer may not be very near to any of the other areas that you're moving in. So this staff was moving around very much, trying to figure out where is my colleague, I need to find her, I need to find medication, I need help with this and that. But instead, they can easily contact each other through chat groups or call each other if they need some help. If you're with an elderly who's frail, who's afraid, who may have fallen, you don't want to leave that person, you want to stay behind. What we've seen in the evaluations that we've done is that when I interviewed one of my colleagues, she said, yeah, we use the telephone to call relatives on FaceTime, we do Google searches on different things that we talk about, we listen to music to reduce stress and anxiety, and we also watch YouTube for different gymnastic exercises that's suitable for the elderly. We also see that the administrative load is decreased when using these phones, and also the digital maturity rises. And looking at the critique, the heavy critique that everyone in healthcare and social care got from the Corona Commission, we can see that this is a way also for us to even smoother, even faster, launching guidelines and new ways of working, which was changed basically every day during the pandemic. Also, a very fun story is that we also have elderly joining in the recruitment processes at the retirement homes. And they sit in on the interviews with new candidates and ask them about different perspectives on their daily life and what they think about working there. To conclude, lessons learned from working with this for many years now is that there's no shortages of ideas. It's just we need the time to execute them. And as we talked about earlier, implementation, yeah, it's a big process, a big step, but after that comes sustainability. We need to work on that too, because we don't have the resources to start up something that doesn't meet a need or a demand. Either in the organization or in the population. But we cannot waste ideas either. We need to take care of them, and we need to have processes internally and externally for that. There are lots of legal and financial aspects, and we need to go through the different agreements that we have all around the place, and acting as one component and one organization in this, you can just imagine how many agreements we actually have and how to update them. It's a tough workload itself. We also need to reduce the time from idea to realization. Endurance and know-how is very important. During the pandemic, we ran sprints. We had one clear goal, we went there. Now it's more like running a marathon, and we have a dispersed goal setting, which is very tough. And the movement from pandemic situation to now is very stressful for both co-workers and for leaders in healthcare and social care. And also very different situation out in the population, trying to meet new demands that have arisen during that time. If you want to learn more about 1000, I suggest that you go to our social media. We have a lot of examples being posted there. And just on Instagram, I think we have about 30 of our different parts of the organization presenting their daily work and what they're doing. So it's quite interesting to hear more about that. And also, if you would like to listen in to 1000-podden on Spotify, you can hear me interviewing my colleagues about the mobile teams, for example, but also other things like exercising with a 95-year-old online. Thank you.
Now we will introduce also Helle Wik, professor in caring science at Gothenburg University. And after that we could have some questions related to this speak, and then we think we will have a general discussion after the second speaker and discussant. Please.
Thank you very much to Karolinska Institute and the Congress organizer for inviting me as a discussant in this session about integrated care, and with special focus on the presentation from Helena that we just heard. And as Sölve said, I'm a professor in nursing at Sahlgrenska Academy at Gothenburg University, but I also work as a deputy head of cooperation, not so much focused on integrated care, but on the prerequisites that's important for integrated care, education. and how we try to bridge the gap between theory and practice, or academy and the healthcare sector. I think it's very important, as we were discussing in the former session, that we really cooperate about the curriculum, like also Professor McCormack was mentioning, and also joint positions and joint PhD students, especially in the municipality where we still have a lack of that. I also work as a visiting professor at Chalmers Technical University at the Center for Healthcare Architecture, which I also think is an important prerequisite for integrated and person-centered care. We need to have environments that actually provide the possibilities of still having a sense of home, even though that I need a lot of services from healthcare, from home care, and from specialists. I think that is what we have to foresee now when we are having this shift in care to integrated care. But that's not what I'm going to talk about now. So I will focus on the presentation from Helena. And what we can learn from your presentation, Helena, was that there are so many potential benefits that can occur when regional and municipality healthcare providers are driven by the common vision and really try to develop and produce and managing an integrated person-centered care. We could see, for example, that it could improve communication and collaboration between healthcare providers. It can empower patients. You had many examples here in your last slides of how you are working with that, and provide them with access to information, resources, and support across different healthcare settings. And also improved outcomes, I guess. And that is something that would be interesting maybe to discuss in the later discussion part of this session. So the question I would like to pinpoint in my presentation is, why doesn't we have TU100 model all over the country when it seems to be so successful? And we haven't. So I would like just to focus for a little bit while on an example, and we can call it Maria's story. And Maria says that after a week at the hospital due to falling during night when I needed to go up to the bathroom, I was referred home again yesterday to my apartment in the city where I lived for the last 40 years. I was both very tired and a little afraid of how I would manage being on my own again, because even though I didn't break anything in the fall, I hurt myself quite badly physically with bruises all over the body, and maybe even more psychological, worrying about when I would fall again. The distance between my bedroom and the bathroom is tricky, especially at night when I feel unstable and a little bit dizzy. When the taxi had left me and I had closed the door, I found a whole bunch of envelopes on the floor in the hall. It was an appointment to the orthopedic polyclinic next week for a checkup after the fall, my monthly visit to the diabetic polyclinic, and an appointment with my physician at my primary health care center, where I go every 6 months. While I was trying to sort out all these different appointments out in my calendar, the doorbell suddenly rang and the home care service paid a visit to check how I was settled after the hospital visit and asking if I needed more service at night coming up from the bed. A few hours later, the physiotherapist popped in to check out on the rehabilitation scheme. And finally, the nurse from the home healthcare service came to check my blood sugar level before the polyclinic visit next week. Everybody is so kind and helpful, but it is so tiring to tell my story all over again, and suddenly I bursted into tears and wondering how I was going to manage all this. This is just a fictive story, but I think you have heard it many times, all of you. And the sad thing is that this is not a new story. If we look back, we could always, already in the 1990s, read the report, The Conductor is Missing, alltså dirigent saknas. I think some of you remember that report from Ulla Gunner at Äldrecentrum. It was also pointing at just these things. 2010, Martina Summer-Maranius had her thesis, Era delar är min helhet, Your parts is my entity, where she was also pointing at exactly the same problem as Maria is telling us. And now, in 2020, Helena Jobe's avhandling, a chain is only as strong as the weakest link, about collaboration in care planning as a person-centered care, was also telling the same story. So why aren't we proceeding? As we have heard before already today, integrated care claim cooperation. And when we listen to Maria's story, it is obvious that she lacks of both continuity and cooperation between her different healthcare providers on all care levels. So Maria, what she needs is a seamless, comprehensive, and tailored care that could have been better coordinated between her visits with the primary care physician, the diabetic polyclinic, the orthopedic specialist, and all the service she gets from the municipality. I think it could also have been much more efficient concerning the use of resources. I didn't count how many people that were visiting Maria just in those few moments that I was telling you, but it was a whole bunch of people where it could have been much more effective, and actually also not duplication of services, which in turn most certainly would reduce unnecessary costs and streamlining the care delivery. And finally, Maria's care could have been more patient-centered to ensure that she received the care that she was responsive to her unique needs and goals, instead of making her sad and exhausted. And I was thinking of when we were listening to Professor McCormack, he was pointing at the matter of words. He was giving the example of patient-centered versus person-centered. And I was thinking about the dialogue we just now have in the part of Sweden where I live, because you know, this nationwide shift of care that is driven by SALAR, the Swedish Association of Local Authorities and Regions, SKR, mentioned two concepts: patientkontrakt, the patient contract, och SIP, samordnad individuell planering, co-produced individual planning. It is two concepts of the same ambition, that we should have an agreement with the person and with the family and with the healthcare organizations. But in my region, the regional part of the healthcare has decided that they will only use the concept patientkontrakt. And the municipality sector, no, we will use SIP. So what is this? How could we think that we would integrate care and work together if we can't even decide about what concepts we should use and when? And of course, this is very confusing also for the person in need of healthcare and for the staff. And integrated care also claims transformation. Integrated care usually is described as a fundamental shift in the way healthcare services are delivered, organized, and financed. And I think with Maria as an example, we can see that she really needs a transformation of healthcare system from the fragmented episodic care she was experiencing after hospital visit to a more coordinated, comprehensive, and patient-centered care. And she also needs a more connected and cohesive system that involves and prioritizes her in the creation of her care plan. So, what can we learn from evidence? Professor McCormack was also stressing that we must need multi-methods or mixed methods, and we need to follow up what we are doing to push the forefront of knowledge further on. In an international perspective, and we have also seen many examples of that already today, we can learn that even that the research base still is limited, there is a growing body, and integrated care programs has shown to improve quality of the healthcare services, enhanced patient outcomes, and reduced healthcare cost. From a Swedish perspective, more and more reports are also coming. For example, from the 1000 example, we can show that adverse events and thereby reduce unnecessary costs are occurring. We can also learn from the healthcare studies on older people, for example, HCAP, that really can stress that older population has never been so vital and eager to be involved in their own health promotion and unhealth prevention. So that is a fortune. And it is also well known that the assurance for older people of having a specific primary physician in their neighborhood enhance older person's satisfaction with care. And we can also see when integrated care programs are implemented, we can see that it also enhances the communication between the healthcare professionals at the hospital and the primary care. Or in an easier way, we know about what each other and what we have done, and we have a communication and dialogue. So, what do Maria need from us for an integrated care? Well, despite the growing body of evidence and good practical examples like 1000, there still seems to be several challenges that need to be addressed in order to provide Maria with a seamless person-centered care. The regional municipality healthcare systems are still organized in a fragmented way, which can make it difficult to provide integrated care. And we had a question here in the early morning about what is the impact of that we have a hälso- och sjukvårdslag och en social lagstiftning, for example. And of course, that is not making it easier. And also integrated care models require adequate resources to be successful. And then I mean both resources in terms of competence and joint positions and all this, but also financial resources. And you were mentioning that also, Helena. Healthcare providers are sometimes resistant to change and may not be willing to adopt new models of care delivery. And therefore, I think, which has not been so much in focus today, I think we must put much more pressure on our leaders and our management boards that they really have to support this. It's not easy as a healthcare professionals on the floor to make a shift in healthcare. And last but not least, there is a need for standardized measures to assess the effectiveness of integrated care models for older people. So my take-home message concerning the actual status of integrated care for older people is that despite these challenges, there is a growing recognition of the importance of integrated care for older people. And many healthcare systems are taking steps to implement integrated care models. So if we all gather together and try to produce more evidence, to follow up and really publish our results, I think we can really have a fortunate future of being successful of integrated care.
We will now continue with a new speaker, Lena-Karin Gustafsson, Associate Professor in Caring Science at Mälardalens University. And she will speak about intensive home rehabilitation in Eskilstuna municipality. Welcome.
Thank you for having me. My first picture was at our new campus at MDU, Mälardalens University. I will present myself, Lena-Karin Gustafsson, and I work as an associate professor in caring science, and I'm close connected to the nursing program in our school. And my research are mostly connected to the close care or nära vård and home care for older people. That's my focus. And now I will present the EHR project. And that's EHR stands for Intensive Home Rehabilitation. And we started to develop the project in 2015. And it was, the idea came from the municipality of Eskilstuna. And they were very interested to develop something that they were inspired from Norway and Denmark also had some development of intensive home rehabilitation, but none of them have connected research to this. They have done this intervention to the whole municipality, but not no control group or so on. So the reasons why they wanted to do something like this was that the society's demographic challenge we stand in front of, and it has been increased costs for the elderly care. And they needed, or we, the whole society, need smarter, cost-effective working methods for elder care. And their aim was to reduce the home care efforts and promote the need of care and get the older persons to stay and live longer at home. And that's why they were very interesting for us to develop research in cooperation with them. So we get some fundings from the municipal to start develop the project, and then we also got Forte foundings and some other fundings too. Yes. And the intervention was that an interprofessional team was recruited, and in this team there was 14 nurses, and this was assistant nurses, 14, and there were 2 occupational therapists, 2 physiotherapists, 2 aid officers, and 1 behavioral scientist, and 1 district nurse in this team, and this integrated team. And it was very important that they were working integrant, and that they were had an interprofessional approach, and not working side by side, but together in cooperation. And this team was recruited, and they were get a joint education at our campus in 4 weeks, full time in 4 weeks. And this education was about person-centered care. It was about setting rehabilitation goals, and it was about health theories, and we used, as earlier speakers, we used Nordenfeld's theory of health, and some other parts of the, like ME, motivation, samtal, and so on. As you see there, motivating interviewing. And after 1 month, the this group also got the location where they sit together. So the rehabilitation staff, for example, didn't go to their own areas and so on. The whole team was sitting together, working together, and have morning sessions and so on when they were together, and then they started to get patients or users to these groups, and the patients that they got that was mostly those who have come from the hospital and asked for home care for the first time. We started with that group. And in the beginning, we did an RCT study. For the half of these, they were half of the people were getting this, and half were getting usual home care services as they always have provided. And both the control group and this intervention group were tested after in the first 3 days, after 3 or 4 weeks, and after 3 months. And then you just, yeah, and this was the instrument that we used. You can see there, it was a lot of physical dimensions that was measured. And also the psychological health there. And we also did these follow-up measures with both groups. And here you can see the EHR group as orange, and the blue one is the ordinary group that get ordinary services. And we could see that in this age group, between 65 and 75, it has a lot of good outcomes. Regarding the use of home care hours. And as you see in the beginning of this, here, in the beginning, the intervention group got a lot of home care, because this team was there a lot of times. It could be up to 8 times a day, doing all the care that they needed, but not the service, because in Eskilstuna Municipal they have divided the home care between services and care, and services are being done by often uneducated staffs, and all the care you have to be assistant nurse, educated assistant nurse, in ordinary care. So it was easy for us to just put in this team to work with the care that usually been done by an assistant nurse without this training. So the control group got the ordinary. So as you see in the beginning, they got more care hours, and to do all these rehabilitation activities that they did. But after 90 days, they needed a lot less. And you can see that this effect kept on being effective. And we could see that it was still going, effective until something else happened. Because something like they broke a leg again or something like that. This group, we also can see that there was a very good effect, and that was a little bit surprisingly for us. We thought that it might be more effective in the younger ages, and maybe they should not concentrate on this older, a group of older patients or users. But we could see that it had a lot of effect. But we could see that, I will talk of this first, then I come to the next group. We can see that the proportions to move into SABO, or more close care, was in the intervention group was very less proportions that moved in. So, okay, but we could see that in the age group of 76 to 85, there were not that big difference. And we were very interested in why that was the case. So we went further with this group and did a research in the journalanteckningar, journal investigation. Yeah, and we also did interviews with those who had this intervention. And we could see that the majority was women, and the average age was 84 years old. Most lived alone, and this might affect the positive or the effect of this intervention. You could see also that the diagnosis had also effect on how the results went. We could see that orthopedic diagnosis was the most common reason to get this intervention. So on. Yeah, we can see that orthopedic diagnosis was potentially the most successful rehabilitation process and linear progression compared to medical diagnosis. And we can see that this diagnosis that have a variance in the disease process had less effect of this intervention. And the diseases or the medical issues that were more linear, that you have something, you have hurt a leg or arm or so on, and then you will rehabilitate. That has much more effect of this intervention. And we could also see that background factor that, for example, living alone was a factor that was not that positive for the progression. Also, mental factors that was make the training difficult because of the lack of trust, for example. So that gave the EHR team a hint that they could revise their inclusion criteria of which patient or so on that should have this EHR intervention in the future and so on. This was a project, and as I said, it was an RCT project, and the politicians have now, when the research phase is over, the politicians in Eskilstuna have decided to make this a permanent team and double it, so the whole municipal of Eskilstuna get the same rehabilitation, home rehabilitation, because it was so successful and they saved a lot of money doing this. These strong efforts from the beginning, and then they could earn money in the long run. So, and we have done some articles about this. We have interviewed the workers in the project, and we also have interviewed patients about the experience of having this intensive home rehabilitation, and we also have did some test on these measurements. We also have written a book that we have a lot of chapters there that takes examples from this process of the project, for example. So, yes, thank you.
Thank you very much, Lena-Karin. And now we will have the last discussant, Janne Agerholm, Associate Professor in Social Gerontology from the Aging Research Center. Welcome.
Thank you very much, Lena-Karin, for this very interesting presentation. My name is Janne Agerholm. I'm Assistant Professor at Aging Research Center. And I have been trying to, among other things, evaluate the integrated care project in Norrtälje, and I'm very happy to be here today to try and reflect a little bit upon these issues. This one. So, I mean, there's a lot of things that you can discuss based on this, but there were three things that I reflected upon. after having the opportunity to read your presentation and also to listen to the other presentations. And one thing is, of course, well, we have talked about integrated care and person-centered care today, but what is actually the difference between these two concepts? Coming from the integrated care aspect or research area, I wondered what is the difference between these two. Another thing is, and we've already touched upon this, the long-term sustainability of these person-centered and integrated care interventions. And lastly, then the interrelatedness between cost in municipal and regional care. And these reflection is, of course, based on the things that we are working with in our research group. And I have I have two of my colleagues here, Ann Liljas and Megan Doheny, who's also been working on these, trying to disentangle the effects of integrated care. So, what is integrated care then? We've been, Anne talked about it this morning, but there are no universal definitions actually for either person-centered or integrated care. And there will be a wide range of definitions if you search online. However, many of these definitions of integrated care directly or indirectly touch on the theme of continuity of care and care coordination. And the current health and social care system is in many ways highly fragmented and also may be poorly designed sometimes to provide health and social care for patients with multiple health problems. And integrated care is then seen as an antidote to this fragmented and uncoordinated care. And one definition that is widely used is the one by Cardinal Spruyvenberg, focusing on the organization of care from a decision maker's point of view. And it's quite long, and I will try to take it slowly. But according to this definition, integrated care is a coherent set of methods and models on the funding, administrative, organizational, service delivery, and clinical level, designed to create connectivity, alignment, and collaboration within and between the cure and the care sector. And this in order to enhance quality of care and quality of life, consumer satisfaction, and system efficiency for patients with complex problems, cutting across multiple services, providers, and settings. And I think that when you are looking at this, there are evidence to suggest that including multiple domains or levels here are thought to be more, give more integrated care and also better patient outcome and system level performance. And I think that Norrtälje is an excellent example of a project where they at least try to combine these different levels and have integrated care on different levels. So what is the difference then between person-centered care and integrated care? And as with the integrated care, there are really many definitions out there on person-centered care. However, according to the Gothenburg Center for Person-Centered Care, person-centered care entails a partnership between patients, their relatives, and professionals in health and elderly care and rehabilitation. And in that sense, I see person-centered care as a wider concept than integrated care. I would say that integrated care could be one way to achieve person-centered care, but there might be many more. But also that integrated care cannot be achieved without person-centered care. And to some extent, person-centered care may be seen more as a philosophy rather than a quantifiable outcome. And maybe, as they say here in Gothenburg Center for Person-Centered Care, is an ethical standpoint. But anyway, I'm now seeing this combination when we search for articles. So person-centered integrated care seems to be the emerging concept. So, as I said, there's a lot of things that we could discuss based on your presentation, Lena-Karin, but I would like to touch about this with the long-term sustainability, because I think we have a lot of examples of really good interventions at different places in Sweden that got money for a project for a certain period, but for different reasons were not able to continue after the project period was ended. And how can we then make effective person-centered and integrated care intervention last longer than the initiated period? I'm not sure I will be able to give you the answer today, but I want to raise the question and maybe we can discuss it later. I think this is an important question, and I will give you one example from a study on healthcare professionals' perceptions of barriers and facilitators for care coordination of older adults with complex care needs being discharged from hospitals that we did with colleagues from Denmark. And here we saw that many, both in Denmark and in Sweden, the nurses came back to this with the safe return as something positive and something that really was a facilitator for care coordination between hospital and home after an inpatient care incidents. And I have one quote here from this. This was a qualitative study. And this is a Swedish nurse from a municipality in the southern part of the region Stockholm. And she says, "We have something that is great here in this municipality. It's called Safe Return. It's a collaboration with the municipality and a private provider of primary care. And then it is a nurse, a physiotherapist, an occupational therapist, who is a team that follow the patient home to make a safer return to home. It gives the patient a very nice transition from the geriatric clinic to the home. And it's often used if these patients have quite large needs, so that you can have this instead of, for example, short-term nursing homes. But then you get this intensive training at home." And then she says, previously there was a similar thing in another municipality, but they ended it or closed it. And unfortunately, just a couple of months after this interview, even this initiative that she mentioned here was ended as well. And the question is, of course, why? Because we have seen these nurses really talked about a lot of different projects that were started, and they thought it had a positive effect, but was ended closely after. And one reason might be lack of integrated funding of integrated care interventions. So this is in Sweden. It's Swedish, but it's an article from Dagens Medicin. Financing was a problem for the Safe Return projects, and there's also the report behind this article. And it shows that it is primarily due to the fact that the municipality felt that they were paying for things that should have been handled in primary care. So since this initiative also integrated primary care interventions, they felt it cost too much. And this leads me to my final reflection, and this is the interrelatedness between cost in municipal care and regional healthcare. And you have shown here, Lena Karin, that this intensive home rehabilitation is effective in reducing home health services for the municipality as well. But I think that sometimes what is done in municipal care to improve older people's health may not be cost saving from the municipality side, but might save cost on the regional side. Yeah, and one example that I will give you here is from a study on inpatient care expenditures in the last year of life that was published last year, just to show you how it can look like. And in this study we found that inpatient care expenditure were much lower for individuals living in institutional care, for instance. And that might not come as a surprise, but here we see the expenditure for the median and the 17th percentile and the highest percentile as well. And it's of course because they are taken care of while they are in the nursing homes. If we further control for income and age and sex, country of birth and comorbidities, we see that individuals in institutional care as well as individuals with home help services have significantly lower costs of care in the last year of life than those without municipal care services. And further, the most likely to have zero inpatient costs in the last year of life is those living in institutional care, where 56% are not admitted to hospital during their last year of life. So I think that this shows that there is an interrelatedness between services provided in municipal care and the need for healthcare on a regional level. And it might call for more integration of funding. Many interventions, like the Safe Return projects, have been ended as they were not profitable for the municipalities, and they cannot afford to continue them, but they might be profitable from a more societal perspective. Yeah. So I'm not standing here saying that we should pull funding necessarily, but I think that we are talking about integrating both health and social care, but there is an issue with then how to provide funding for these initiatives.